So thanks everybody. So thanks for bearing with us with the technical hitches there at the last minute. So my name is Chantal Migone. I'm a consultant in public health medicine at the National Immunisation Office. And I'm joined by my colleagues here in the NIO. So we have Anita Gafour-Butt, our communications manager, Louise Lyons-Males, who's a senior medical officer in the NIO. And then we have the NIO team here as well. So there's Sarah Solomon that you heard there, who's our project manager, Alice Muthu and Anya, who are members of our clinical team as well here. So you're very welcome. And just before we start, I just wanted to say thanks to everybody who helped with the development of the slides for the webinar, and also thanks to Dr. Helena Murray from NIAC, who's joining us today as well. And Helena has said that she's happy to answer questions directed on behalf of NIAC at our webinar. So just a little bit of housekeeping. The webinar is for HSE staff, and we're going to cover clinical advice. So we're not going to cover operational queries or questions regarding IT systems or GP payments. It's going to be focused on the clinical information. As you know, when there's a change to the childhood immunisation schedule, it has to be agreed with the GPs who give the vaccines, and those negotiations are not finalised yet. So for that reason, we aren't launching the campaign yet, and we'd just ask you not to share some of the information on social media that Anita will show you later. There's a lot of people on the webinar, so if you could type your questions in the chat, the NIO clinical team will answer questions. And Helena Murray from NIAC is also available to answer questions. But if you have questions for Helena, if you could put in the chat, this is a question for NIAC, so that she can identify easily the questions in the chat. Just to say, the updated NIAC chapters are awaited, so they will be available with the updated schedule. And also we will have updated information on our website, both for members of the public, parents and guardians, and also for healthcare professionals. We'll also be launching a new e-learning module, the Primary Childhood Immunisation Programme on HSE land. So we've worked on that with the ICGP and for the professional development coordinators for practice nursing. So that'll also be available. And if you could please keep your cameras off and stay on mute, just because there's a lot of people on the webinar, so we're trying to keep the bandwidth for the presentations. And the meeting will be recorded as well. Okay, so let's start with the changes to the primary childhood immunisation schedule. So the schedule is changing for babies born on or after the 1st of October of 2024 this year. And the last time the schedule changed was in 2016. So it's a big development in our immunisation programmes. And what prompted the PCI schedule changes? With a little bit of background, the first thing is that the manufacture of the combined Hib-Men-C vaccine, which is given at 13 months, is ceasing, in fact, has ceased after this year. And because of that, supplies of the vaccine will expire in March 2026. So therefore, there had to be a change to the schedule to accommodate this change in the availability of vaccine. And the other big change is that a great development, which is that the Department of Health accepted the recommendations of the National Immunisation Advisory Committee to include the Varicella vaccine in the childhood immunisation schedule. So that's a really great development for babies, children and their families as well. So what changes are being made? Well, there's no change in the number of visits or the timing of the visits. But there are some changes. So the first change will happen at the 6-month visit, where the Men-C vaccine will no longer be given. The second change is that the Varicella vaccine will be added at the 12-month visit as a single Varicella vaccine. And the third change is that the combined Hib-Men-C vaccine that's given at 13 months will be replaced with a Men-C vaccine and a 6-in-1 vaccine. And you'll see here that the babies that this will apply to are those born on or after the 1st of October 2024. So therefore you can see there in blue when we'll first see these changes. So those babies will be 6 months in April 2025, they'll be 12 months in October 2025, and then they'll be 13 months in November 2025. So what will the schedule look like? So you can see here the two different schedules, and we've tried to make them really visually different because for a while there will be 2 different schedules running depending on the date of birth of the child. So first change is at 6 months with the removal of the MenC vaccine. Next change is at 12 months with the addition of the chickenpox vaccine. And then the next change is at 13 months. I just ask people to please go on mute because you could just hear some background interference. Thank you. We can still hear some people not on mute. So if you could just check that you're on mute. Thank you very much. Yeah. So the next change is at 13 months with the replacement of the Hib MenC vaccine with a 6-in-1 vaccine and a MenC vaccine. And which schedule do children follow? Well, as I said, for a while, there will be 2 schedules running, and it's the child's date of birth that decides which schedule they're on. So if they're born before the 1st of October 2024, they're on the old schedule that we're used to. And this also applies if they need to catch up. They need to catch up with the schedule that was in place at the time that they were born. Those born on or after the 1st of October 2024 are on the new schedule, which includes Varicella vaccine, and they will catch up eventually to that schedule as well. So the child's date of birth decides which schedule they're on. So a little bit of background to the recommendations and why were these recommendations made? So the first is why remove MenC at 6 months? Well, NIAC reviewed the international evidence and recommended that the international experience shows that 1 dose of MenC vaccine given in the 2nd year of life with a booster dose in adolescence is sufficient to protect against severe disease and establish herd immunity. And that herd immunity helps to protect younger children. And this is the strategy that's used in a lot of countries, including in the UK, in the Netherlands, and in Canada. And they give a MenC dose in the 2nd year of life with a booster dose in adolescence. And they've shown that this is safe and effective and has not resulted in an increase in incidence of MenC in younger children. So we're then going to move on to the changes at 13 months. So as I said, the vaccine supply for the Hib MenC is stopping. So therefore that there had to be a change. And NIAC reviewed which Hib containing vaccine would be optimal in its place. And reviewing the evidence, they concluded that an additional 6-in-1 will provide adequate protection against Hib, but it'll also enhance protection against the other components in the 6-in-1 vaccine without children needing an extra injection. And this is particularly beneficial because we've seen an increase in pertussis activity in many European countries, including in Ireland. So offering an additional pertussis containing vaccine between 11 and 24 months will result in enhanced protection and also will align with other European countries who give a pertussis containing vaccine in the 2nd year of life, and also enhance protection against other infections like polio and diphtheria, which have re-emerged in some countries, including in some countries in Europe. Diphtheria has been seen, for example. Okay, so then we're moving on to the Varicella vaccine, which is the star of the show and the great development in our schedule. And we all know about chickenpox or varicella infection. It's a very infectious illness caused by the varicella zoster virus. It's very infectious. So if one person in a household gets chickenpox, almost everybody, or likely everybody in that household, will develop chickenpox if they're not immune. And there's the typical generalized pruritic rash, which is vesicular and can have mucosal involvement. And children and adults are infectious until all the vesicles have crusted over, which typically takes 5 to 7 days from the onset of the rash. And even though infection is mild in many children, it still causes significant disruption. They can't attend childcare, they can't attend school, parents have to take time off work to look after them. And if there's a number of children in a family, there's going to be one child infected, and then because of the long incubation period, it's going to be the next child and the next child. So a lot of disruption to family life, school, childcare and work. With regard to varicella epidemiology in Ireland, it's very common. Irish seroprevalence data shows that 92% of the population is infected by 10 years of age. And varicella hospitalisations have been notifiable to public health since 2011. And prior to the pandemic, there were approximately 100 people hospitalised per year with varicella, majority of them children under 10 years of age. The incidence fell with the COVID-19 pandemic, but then we saw a rise in cases again. And very concerningly, in mid-2022, we saw that chickenpox infection was associated with infectious group A strep infection, which is, as you know, a very nasty, severe infection, which results in septicemia and has a high mortality rate. And hospitalizations have increased. So in 2023, there were 170 cases hospitalized with varicella in Ireland, the majority in children under 10 years of age. So it does cause significant burden in terms of morbidity as well. The complications of varicella infection include pneumonia, secondary bacterial infections of the skin and soft tissues, which are relatively common. It is associated with invasive group A strep, which, as you know, can be a devastating infection resulting in septicemia and death, meningoencephalitis, hepatitis, bleeding disorders, glomerulonephritis, and myocarditis. And in non-immune pregnant women, varicella infection in the first or second trimester can result in congenital varicella syndrome. And if a mother is infected near term and is non-immune, it can also result in neonatal varicella infection, which has a very high mortality rate. So, in terms of introducing a universal varicella vaccination programme, NIAC has recommended this because countries with universal varicella vaccination have been shown to have a reduced incidence of hospitalisations and complications of varicella. And this was supported by a HICWA health technology assessment, which concluded that varicella vaccination is highly effective and safe in preventing varicella, including severe disease and its complications. And varicella vaccine is not new. It's been available in Ireland for many years, but up until now, parents had to pay for varicella vaccination for their children. So obviously that was very inequitable and not the ideal situation. So it's fantastic that now we have it included in our primary childhood immunisation schedule. And other countries have had varicella vaccine in their schedule for many years. Germany was the first EU country to introduce it, and they saw cases reduced by 70% and hospitalisations by 50%. The USA have included it in their schedule since 1995, and there's evidence that the population risk of varicella through a universal vaccination programme that's been going on for a number of years has reduced the risk of varicella by up to 90%. And this risk was observed at a population level for 15 years for both vaccinated and unvaccinated individuals. So introducing the schedule also has benefits for other people who are not vaccinated. And in Australia, they have also seen a reduction in congenital varicella syndrome and neonatal varicella infection since introduction of the vaccine in their programs. So really good evidence of it being highly effective. And NIAC have recommended a 2-dose schedule. So the first dose, 1 dose is 60 to 85% effective against varicella infection. 2 doses are 87 to 95% effective against varicella infection. But it's important for parents to know, and I suppose for everybody to know, that 1 dose is very effective in preventing moderate to severe varicella infection. So NIAC have recommended the first dose of varicella to be given at 12 months and the second dose when children are in junior infants in school, when they're 4 to 5 years of age. So there is a gap between the first and second dose, but one dose is very effective against moderate and severe varicella infection. So which varicella vaccine has been recommended by NIAC? Well, varicella vaccine is a live attenuated vaccine, and there are 2 varicella vaccines available. One is a single antigen vaccine, Varivax, and the other is a varicella vaccine which is combined with MMR, which is the MMRV, marketed as ProQuad vaccine. And NIAC have recommended that at the 12-month visit, a single antigen vaccine is given. So that's the Varivax vaccine. And that's because in clinical studies, the risk of febrile convulsions after vaccination at 12 months was higher in infants who received the combined MMR-V versus those who received a separate MMR and varicella. But it's important to stress that the risk is low for both. So for that reason, NIAC recommend that dose 1, given at 12 months as part of the primary childhood immunisation programme, is the single antigen varicella vaccine, and dose 2 is given as MMR-V at 4 to 5 years of age when children are in junior infants. And just to say that because varicella vaccine applies from children born from the 1st of October 2024, those children won't be in junior infants until they're 4 to 5 years of age, so in 2029. So who can get the varicella vaccine? Well, varicella vaccine can be given to most children. It's a very safe and effective vaccine. And a question that's sometimes asked is about children who are living with non-immune pregnant women or with immunocompromised persons. And it's especially important that children who are living with these vulnerable individuals are vaccinated with varicella vaccine to protect them and therefore protect family members from exposure to varicella infection. Who can't get the varicella vaccine? So what are the contraindications to varicella vaccine? Well, like all vaccines, anaphylaxis to the vaccine or any of its constituents is a contraindication. The vaccine is a live attenuated vaccine, so therefore significant immunocompromise is a contraindication. Active untreated TB is a contraindication, and individuals with the family history of congenital or hereditary immunodeficiency, unless the immune competence of the recipient is demonstrated, is a contraindication. And pregnancy is also a contraindication, but obviously that doesn't come into the primary childhood immunisation programme. We'll now go on to the precautions to varicella vaccine. So like all vaccines, an acute febrile illness is advised to defer until recovery. In our primary childhood immunisation schedule, at 12 months, varicella vaccine is given with the MMR vaccine, but NIAC advised that if the vaccines aren't given at the same time as MMR, then we should defer the varicella vaccine for 4 weeks because it may not be as effective if it's given at too short an interval. So you either give them at the same time or you defer for 4 weeks. The vaccine should be delayed if the child has received an antibody-containing product like blood products, for example, in the recent past. And salicylate-containing medications should be avoided for 6 weeks after vaccination because of the risk of Reye syndrome. Receipt of certain antiviral medications 24 hours prior to vaccination is a precaution, and then pregnancy should be avoided for 4 weeks after receiving varicella vaccine, but again, not applicable to our PCI programme. So what are the side effects of varicella vaccine? So it's been given, as I said, for a long time, so included in the immunisation schedule in the US since 1995. So there's lots of safety information about the vaccine. And common reactions include pain, redness or tenderness at the injection site, fever and irritability. Another common side effect in 2 to 3% of children is a rash after vaccination. So that can be either localised at the injection site or more generalized, and it can also be vesicular. So there can be a small number of lesions that look a little bit like chickenpox, but the number of lesions is small. So the median is 2 at the injection site or 5 if it's a generalized rash. So it's a small number of vesicles. So just a little bit about this post-vaccination rash. It can occur 5 to 26 days after vaccination, and it's self-limiting and doesn't need treatment. But NIAC advised that if children get this post-varicella vaccine rash, they should avoid contact with non-immune pregnant women, with babies in the first week of life if their mothers are not immune to varicella, and with people with severe immunocompromise. And this is because there is a very, very small risk of the attenuated vaccine virus causing infection in people who are vulnerable. But the risk is very small. So there's evidence from the US that in 56 million doses of vaccine given over 10 years, there were only ever 6 reported cases of varicella infection, and these were mild. So that is calculated as a risk of 1 in 9 million. So it's a very, very small risk. So I'm just going to go to a few FAQs And there's only a few here. We will have an FAQ document for healthcare professionals with a lot more in them. So the first one is, what about anyone born before the 1st of October 2024? What schedule will they follow? And we've talked about this already. Children should follow the schedule that was in place at the time that they were born. So if they were born before the 1st of October 2024, they follow the schedule that was in place at the time that they were born, which is the schedule, the old schedule, if you like. And this includes if they need to catch up to vaccines. They need to follow the schedule that was in place at the time that they were born. So there's no catch up for varicella vaccine for children born before the 1st of October 2024. So that's important to know, because I'm sure that's a question that a lot of people, including parents and guardians, will ask. The other one is, should a child living with a non-immune pregnant woman, a non-immune infant, or someone with immunocompromise get the varicella vaccine? And the answer is absolutely yes, because it's really important that children are vaccinated to reduce the risk of exposure to infection through vaccination. And the benefits of reducing exposure to infection through vaccination far outweigh any risks from children getting this vaccine rash that we talked about. As I said, it's extremely rare for transmission to occur from a vaccine rash. It's, I suppose, a very remote risk. If it's not possible to avoid contact, and we know it isn't in many cases, it may not be possible to avoid contact, then NIAC advised that advice from a specialist should be sought. So that would be the specialist treating the person with immune compromise, for example. And there will be information for parents available on our website as well. So in summary, the new schedule is for those born on or after the 1st of October 2024. Those born before that date should continue on their schedule at the time that they were born, including for any catch-up vaccines. There's no change in the number of visits or the timing of the visits. The change to the new schedule are the removal of Menc at 6 months, the addition of chickenpox vaccine at 12 months, the replacement of the Hib Menc by a Menc and a 6-in-1 at 13 months. Varicella vaccine is safe and effective and has been used for many years in other countries. And just to say to please check the NIAC website and the NIAC guidelines for the latest recommendations. They aren't on the website just yet, but they will be available. And also to check our website as well. And I'm now going to pass you over to Anita, who's going to talk about the campaign on the new schedule. And Anita, I'm happy to do the slides for you. So just tell me if you want me to move the slides.
Thanks very much. Hi, everybody. My name's Anita. I'm the comms manager for the NIO, and I'm delighted to be here to talk about our new PCI campaign. This campaign is aimed at parents, and we will also have information for healthcare professionals. To start, go through our main campaign objectives, and these are to raise awareness amongst parents of babies born on the 1st of October 2024. We also have an additional campaign objective there, which is to raise awareness amongst pregnant mothers who are due to give birth on or after the 1st of October. I suppose in terms of the fact that we have a new vaccine schedule running alongside an existing schedule, and we just need to ensure that we have a clear communications approach to this campaign. So at phase 1, we want to provide a clear and comprehensive information campaign about the changes through various channels and where parents are at. And at phase 1 and 2, we will tailor our communication efforts to reach high-risk groups, for example, underserved communities and unvaccinated babies as well. You can just move along. Thanks, Chantal. We have a final campaign objective there, where we'll promote the PCI vaccine and aim to increase acceptance and uptake of the vaccine schedule. Move on to the next one, Chantal. Thank you. So we have two main key messages. So the first one there is, if your baby is born on or after the 1st of October, you'll be offered a new vaccine schedule. And then we have another key message there. If your baby is born on or after the 1st of October, you'll be offered the varicella chickenpox vaccine as part of the new baby vaccine schedule. And in addition to that, we have 5 broader factual messages that are listed there. And we will also have 2 main websites where you can find out more information. The first one is our own website, which is immunization.ie, and the second one is aligned to the HSE A to Z site, which is chickenpox there, and the links are there for you to see. Can move on, Chantal, thank you. So how will we reach parents? Well, we know that parents are active on social media, so we will be promoting our content calendar across HSE Instagram and HSE Meta, HSE TikTok. They all have large followings, and we will also be promoting our messages across the Ultimate Maternity Guide and the Mums and Tots Winter Edition. We'll also be sending out letters to parents via the HSE. Just move along, Chantal, thank you. So we will be looking to reach out to migrant communities as well, and we will be working actively with Cordia to do this. They have an online site which holds vaccine information in 5 community languages. This information will be shared across Cordia's social media sites, WhatsApp and Telegram as well. In addition to this, we'll be sharing a partner pack to organisations who work directly with migrant communities, and we'll also be sending out resource packs via our local HSE social inclusion teams. Can move on to the next slide, Chantal, thank you. So in terms of translations, we also have a new graphic which we've produced to accompany this campaign, and this is being translated into 13 language options, including English, and the images have been approved by NALA, and the content has been given a plain English mark by NALA as well, and the infographic will be available to download from immunization.ie, healthpromotion.ie and healthconnect.ie as well.
Hello.
To the next slide, Chantal, thank you. So in terms of general resources, where can you find out more? So you can see we've developed a new guide there for parents. We also have an A3 poster available outlining the schedule. We have an after immunisation information pack there and a new immunisation passport as well. All of these resources are available to download from our website and also to order from healthpromotion.ie once the campaign launches. We also have a new infographic, which I mentioned there earlier. This will be available to download from healthpromotion.ie from our new website in 13 languages. Can move on to the next slide there, Chantal, thank you. So in terms of reaching out to healthcare professionals, how we engage with you, well, we know that the most effective way to do this and the quickest way to do this is to have the information available online. So we will be looking to promote information across our HSE Twitter page, HSE LinkedIn page, and we will also be issuing our NIO magazine in September, which will cover the main clinical and programme updates, which you have just heard from Chantal here. And we will always issue a partner pack at every campaign launch, and this will go out to all our partners. Just move the slide along, Chantal, thank you. Where can you find out more resources if you're a healthcare professional? Well, there's 2 main links there, where you can find the FAQ document for healthcare professionals, and you can also take part in the new primary childhood immunisation e-learning module at hse.ie. And I think that's all I have, Chantal, thank you.
Thanks a million, Anita, that's great. Thanks for that. And we're all very proud of our new resources. I know a lot of work has gone into those as well. So the next session is now going to be given by Louise Lyons-Mail, one of our senior medical officers, and it's a really important part of the webinar because it's about vaccine acceptance and vaccine hesitancy and what you can do if you're talking to parents who might be hesitant about vaccines. So Louise, I can move the slides on for you as well.
Great, thanks Chantal. So this part is going to be around 10 minutes, and I'm going to discuss vaccine acceptance and vaccine hesitancy, focusing on healthcare worker communication around the issue. So next slide, please, Chantal. So many factors influence people's decision to be vaccinated. These are called the behavioural and social drivers of vaccination. So you can see from this that people are complicated and influenced by many things. The first is trust. Trust in the government, in the health service. If someone has had a bad experience in the health service, they are less likely to trust vaccines. Another example is trust in government. Some Roma communities have been badly treated by governments in the past, and this may factor into their trust in vaccines. What others are doing or saying in the community is very influential. Here, healthcare professionals especially are really influential. If they recommend a vaccine, then that is a really important factor in a person's acceptance of vaccination. Other priorities and life stressors, such as financial or housing issues, may affect motivation to get vaccinated. Unless they are very motivated to get vaccinated, they may decide not to, or may put it off and delay vaccination. Then, even when someone is motivated to get vaccinated, they may be affected by practical issues, such as how easy or complicated it is to get vaccinated. For example, if they can't get an appointment, or if the person on the phone isn't nice to them, or if they can't understand the information about where to get vaccinated. So it's important to get that part right too. And we have a problem with GP access in many areas now, for example. Next slide, please. So the first thing we can do is to build trust in vaccines using skilled communication about vaccines. And we will go through some of these techniques in later slides. The second thing is to make vaccination easy and convenient to facilitate parents to make appointments and reducing practical issues to promote vaccine uptake. So next slide, please. Everyone has a role in making vaccination easy and convenient. The GP receptionist or person answering the phone to make appointments is really important. They should be aware of the importance of immunising babies on time and not delaying vaccinations. Reminders also work. These can be text, letter, phone call, and verbal opportunistic reminders, such as reminding patients about vaccines when they are at an appointment for something else, such as the baby developmental checks. GP practice software, reminders, and prompts are also useful for the doctor or nurse to recommend vaccination when the patient is attending for something else. Providing vaccination close to where the person lives is important, such as the use of a mobile vaccination unit for vaccination in congregate settings. Next slide, please. To address vaccine hesitancy, it is all about trust. You as nursing or medical professionals are very much trusted by the public. Next slide, please. Vaccine hesitancy is a continuum. Generally speaking, about 10% of the population in high-income countries like Ireland may have some level of hesitancy, where they are unsure or have some concerns about vaccination. Of course, this varies by vaccination and by population, but that's a general rule. So we're going to focus on this undecided category, the orange, yellow, and pale green areas in the chart. And that's really where you could make a difference and you could be very influential. Next slide, please. We know how it can be challenging to talk to someone who is hesitant about vaccines. So how do you do that? First of all, it's important to actively recommend vaccines. Then the World Health Organization recommends a presumptive approach. For example, saying to a parent, it's time for your baby's vaccines at 2 months, rather than asking them if they have thought about vaccination. How you talk about vaccines is more important than what you say. There is also a technique for talking to someone about vaccines that is designed to build trust in vaccines called motivational interviewing. Next slide, please. Research has shown that using motivational interviewing tool or strategy increases vaccination rates in both children and adults. Next slide, please. The first step is to understand where the person is on the vaccine continuum. Is the person in the unsure or concerned category? And this is where your communication approach can really make a difference. Remember, it's a very small proportion who are truly against vaccination, about 1.5%. Next slide, please. The World Health Organization recommends a motivational interviewing approach and aims to bring the person to make a positive decision about vaccination. It involves asking open-ended questions. For example, can I check with you what you're worried about? Stress the positives. Say, it's good you're asking questions. I know you want to do what's best for you and your family. Confirming that you understand their worries, but don't agree with their worries. You could say, it can be worrying when you read things like that. Summarize what they've said and check your understanding. You could say, from what you've told me, you want your baby to be healthy and well, but you read on Facebook about a side effect of the vaccines that worries you. Is that right? Offer information and advice. Can I tell you about the vaccines and about my experience of the vaccines? Remember to stress the positives that the vaccines will protect against illness. And describe the next steps. Now you're going to phone the GP after this and make an appointment with the nurse for your baby's vaccines. Next slide, please. And next slide, please. Thanks. Do give information about specific concerns. You can find useful information on immunisation.ie, for example, about vaccine ingredients or specific vaccines, such as the MMR vaccine. Share your own experience. For example, you could say, you know, my children have all had the MMR vaccine too. Give practical information. For example, you could say, I can book you in with the doctor or the vaccination teams at a certain time. Offer a leaflet or share information they can read at home. They could visit hse.ie or immunisation.ie, where information is available in different languages and different formats. And finally, leave the door open. And if the person is unsure, let them know that they can come back and talk to you about the vaccines anytime. Next slide, please. What doesn't help? If the conversation descends into an argument or debate, it won't work. Don't bring up additional concerns that the person did not mention, as this can help spread rumours and misinformation. For example, if someone is worried about the ingredients in the MMR vaccine, don't say, and by the way, the rumours about the MMR vaccine and autism are also not true, as this would actually likely propagate or spread these rumours. Next slide, please. And what if somebody is anti-vaccine and doesn't trust vaccines, refuses all vaccines, and may have very strongly held beliefs? These conversations can be really challenging. Many of us have spent a long time trying to talk to someone who is against vaccination. There is a way to approach this. And just to reassure you, it is very difficult to change somebody's mind if they are in this category. But what you can do is build trust between you and that person involved and maintain your relationship. Affirm the positives. So you've thought a lot about this. Ask them for permission to talk about the vaccines. And if they say no, then that's okay. And if they say yes, move into the motivational interviewing approach. But if it descends at any time into a debate or argument, don't continue. You could say, I can see you've made a decision, but always leave the door open and advise them that if they would like to speak to you about this again, then you're happy to answer any of their questions and offer advice as appropriate, such as giving advice about protecting themselves against infection. Next slide, please. We would really encourage everyone involved in vaccination to take our e-learning module available for free on HSE Land, which takes you through how to talk to someone who is hesitant about vaccines. The good thing about this approach is that it should actually simplify the conversation and make it less stressful for everybody. Next slide, please. There's a lot of vaccine information available on immunisation.ie, including discussing vaccine ingredients and toolkits to increase vaccine uptake. The National Social Inclusion Office website has a section on multilingual vaccination resources, which is very useful. There are also further resources if you're interested on the Children's Hospital of Philadelphia website and University of Oxford Vaccine Knowledge Project website. Next slide, please. Thank you.
Thanks a million, Louise. Thank you very much for taking us through that. And I'm going to stop sharing now if my computer will let me. Just a second. Yeah, I think that's done now. Okay, so thank you very much to all our speakers. So I hope we've given you an overview of the changes to the primary childhood immunisation programme that are coming our way very soon. And I suppose I know we have a mix of people attending the webinar. So we have public health nurses, we have some of the HSE vaccination teams who are vaccinating our vulnerable migrant population. We have public health department staff, National Health Protection Office staff and other staff. So it's really fantastic to see so many people attending about the new schedule. And we look forward to working with all of you on promoting vaccines. And we will be providing, as I said, more information on our website, all those materials. And of course, when it comes to next year, near the time when children start getting the chickenpox vaccine, particularly promoting that vaccine as well. So thank you very much. I'm just going to ask our speakers and our NIO panelists if there's anything that they wanted to say. And then also to Helena from NIAC, thank you very much for attending. And if there's anything that you wanted to say as well, at this stage. No, that's great. And well, thank you.
Right.
Oh, go,
Chantal,
Helena. Yeah, sorry. Go ahead.
It all looked very clear and in keeping with the the NIAC guidance. So yeah, well done and good luck with introducing it. And thanks to everybody for their interest. You've huge number of people on this webinar. That's very good.
Thanks, Helena. Thanks for your support as well. So
Yeah.
thanks a million, and we'll see you all again soon, and to let you go for a slightly earlier lunch than anticipated. So thanks a million.
Okay, that's great.
Bye. Bye.
Bye.
Thank you.